So this is a tube I give every year, anterior mediastinal masses. If you've already seen this tube, take it as testing. I'll ask questions. I'll ask questions of everyone. Make sure that you commit to answers. And if you haven't heard this tube before, hopefully you get lots of new stuff that maybe you haven't thought about. I remember when I just started studying for my Part 2 exam, I thought, how on earth did I not know this critical information? And it's because it's very super specialized. You just don't see it that often. When you see a mediastinal mass, anterior mediastinal mass, it's just not that, it's usually not that big, or it's, multinodular goiter, which doesn't have too much impact in most circumstances. Good. So yeah, we'll make this interactive. Everyone commits to answers, active recall and decision making. Even if I'm just asking someone, I'll give you everyone some time. So please commit to some answers, write down your answers. And we'll go through the core parts of topics without too much detail, because I think that this is best served for me to try to get to the points where things could really, go wrong in the exam, or like where difficult decisions exist. Right or wrong, again, we don't care. You're all intelligent, capable people. So let's embrace our errors, mistakes, progress, not perfection. We're never too old to improve. This is straight for an examiner. This is the aim. So the aim is to create a realistic patient scenario that evolves, progresses, and tests the candidate's abilities at multiple points in this timeline. A couple of things that I just got information from one of my trainees that I work with, who went and who unfortunately failed the exam, but they gave me the examiner sat with them for like 60 minutes and gave them a lot of feedback. And it's very important that in this Viva, it's a balance. That the way you fail this Viva is not taking cues. So if they say, are you sure, and you don't go back on, that's kind of giving you a lifeline to test whether you really meant what you were going to say. So please take cues, very importantly. If you're too forthright with decisions, like we all talk about, just commit to a decision, it's got to be roughly, I think, around the 70% in terms of certainty. You can't be that person who's just like, this is what I'm going to do, and that's the best way, because that sounds odd, and we all know there's just risks and benefits. And you definitely cannot be the person who's like, I could do this and I could do this, and I'm not going to make a decision either way. Commit to a decision and be on that 70% conviction range where there's bad stuff, but you're gonna make a decision and the problems. Just remember the Viva then often changes as it progresses. So just go with the flow of it. You say something else happens. You say something else happens. It's not that you're doing badly. It's just that the Viva just keeps progressing, and you'll get very familiar with it as you do more Viva practice. Again, the examiner goes that you test clinical judgment, decision-making, and conflicting prioritization. Hopefully we'll go through all of those things in this session. Okay. Hey, so the first thing I'm going to get you to do, I'm just going to ask for a volunteer to describe this chest X-ray.
Yeah, it looks like totally normal.
Yeah, good one. Okay, well done. David Wang, describe this chest X-ray.
This is a unlabeled chest X-ray. Assuming this is an AP projection, there is insufficient exposure of the patient. There is adequate penetration with very minimal rotation. The gross abnormality is reduced interstitial lung markings, which may suggest evidence of emphysema, as well as quite horizontal ribs with 1, 2, 3, 4, 5, 6, 7, 8, 9, with almost 10 ribs posterior, which also may signify hyperexpansion in context of emphysema, and slightly flattened diaphragms. Looking closer, the trachea is midline. There is no there is no effusions, there is no consolidation. There is the cardiac contours are within normal limits. Bone-wise, there is no gross bone deformities, fractures, bone deformities, nor is there any evidence of soft tissue injury. In conclusion, I think there's also slight reticular nodular patterning, especially in the right lower zone. my overall impression of this patient is a female with COPD / emphysema.
Okay, Dave, what's your framework? Was it, first of all, I'm going to say that I think you can probably read chest X-rays better than I can, and that's great. You need to be at that level for this exam. What's your system, just for everyone to know? What's your framework?
My approach is to say that, so to do your normal name, patient, age labeling, AP, inspiratory, expiratory, that type of thing, and then go through, then doing the whole rotation, penetration, exposure. And then I would say what I grossly think is the biggest problem. And if that was what they wanted to move on, that's it. Otherwise, I'd go through airwise. So having a look at, middle to peripherals. And then having a look at your cardiac, and then having a look at your bones and soft tissue.
Yeah, good. So I've got this format of similarly airway, so A, B, C, D, but definitely having your demographics and your exposure and the quality of your chest X-ray at the start, absolutely. So look, with this chest X-ray, I've just got this from the internet, and it's actually just a normal chest X-ray. So I'm trying to figure out where that would fit in. I feel like when you said the most grossly abnormal quality of this is the I forget what you said, that led to COPD. And maybe you're right. Maybe I've got this photo from the internet and it's incorrectly labeled. But let's say if something looks relatively normal, and maybe it's just the fact that it's a picture, and when Ansgar gives you pictures, is it going to be high resolution? I don't know. Maybe using the word grossly abnormal may be a bit of an overcall. Again, because I'm not a radiologist and I'm just taking this picture on the internet, I can't own that suggestion. But all I've got here is it's a normal chest X-ray. But the most important part of that was you had a really solid system. So maybe you could say, look, demographic parameters, exposure, rotation, etc. This looks pretty normal, but I'm going to go through it systematically. And the exams were great, it's normal, or whatever. Let's keep going. This chest X-ray, I can't really own it because I've just taken it from the internet, and it's just described as a normal chest X-ray. With the way you did it, I really like the fact that you have a really solid structure. You went through all of it pretty quickly. And when you have facts and data like that, it's very hard, I think, for the examiners to go, well, this person was inadequate, because they're just giving me lots of very truthful statements. The one thing I'd add then is that, this does look kind of normal to me. Again, I'm not a radiologist, can't back that up too well. To say this was the grossly abnormal quality of something was probably a bit of an overcall. Just a very humble opinion about that, and I could be wrong. But let's move on from that. So we've gone through a system, demographics, parameters of the chest X-ray, airway, bones, cardiac, diaphragm. Just, if you're not sure about something, if there's no gross abnormality, just be able to talk to it and get some stuff out there. So next thing.
Oh, is that me?
Yeah, go for great.
Okay. So this is a CT chest, unlabeled. So just looking at the airways, just going through systematically. So airways, there's no gross consolidation or mass effects in the visualized area of the lungs. I'm really struggling to see the trachea, but I believe the trachea is deviated from the midline to the right-hand side, as indicated by the superior arrow. It also appears, I'm not sure if it's narrowed or if it's got a, yeah, it's quite tricky. I mean, I'd love some clinical correlation for this patient, just to see what's going on. But it appears to be a narrowed portion, as indicated by the superior denser arrow as well.
Okay, good. So Greg, what you did there was an important thing that you should never do in the exam, which is to ask more questions of a question. So you make your assumptions and just go for what you've seen, and you actually saw some, really important things. So when you see, a tracheal issue like the one you saw, what do you think is the most important things to describe, or what you'd like to know?
So you'd want to know the clinical context that this patient, the CT has been done in. So whether this patient has
Clinical
come in.
context, how about on the picture itself? What are the parameters, numbers, facts that you would ideally like the radiologist to tell you about on this?
What do you want the radiologist to tell you about?
Or you can do it with measurements, I guess.
Yeah, so you'd want to know the narrowing, or the minimum aperture of the narrowing.
Mhm.
You want to know the level of narrowing,
Mhm.
or degree of stenosis. You'd want to know the midline shift, or the deviation from normal. You'd want to know, we've already got level. So you want to know level, stenosal percentage, or minimum diameter. You probably want to know angle as well.
That's fine.
Yeah.
What do you think is causing this? What could be causing this?
So there is a mass or opacity in the superior aspect of mediastinum, probably representing a soft tissue mass, which is causing deviation and narrowing of the trachea. This is indicated by a widened superior mediastinum.
Sounds good. Sorry, got the wrong notation. There's CT, large anterior mediastinal mass causing extreme compression, right, with deviation of the trachea. And then we've got a few measurements for how compressed it is. And you're right, like, really what I want to know is how much, what's the aperture? What is the stenosis level? How much deviation there is, and how far up from the carina is also usually an important thing for me as an anaesthetist. I often want to get past the lesion if I'm doing any intervention on my own. So let's take this scenario now. You're called to assist in CT, 35-year-old female, no past history, no meds, no allergies, just keep it simple. Undiagnosed anterior mediastinal mass for a CT scan. The patient cannot lie flat, and they would like so you get called in, and they would like you to give some patient some sedation or GA. What do? Everyone just make a decision of what you want to do. Take 10 seconds to do that, and tech. I'll ask you at the end of that. Excellent. So hopefully everyone's kind of committed to an answer. Again, I don't want it to just be the person I asked that gets put on the spot. So yeah, David Koo, what do you reckon? What would you do?
I would ask the senior colleague for help.
No deal.
Considering this is a difficult patient with significantly symptomatic anterior mediastinal mass, who already can't lie flat, and the GA is going to be very high risk. So my priorities include, number one, this is a remote location and a very unwell patient, potentially requiring with a difficult intubation or difficult airway process. Number two, second priority is ensuring that we can continue this patient to have a spontaneous ventilation, and intubation post the mass, and ensuring the airway is secure for the CT. And number three priority is, what is this mass? What are they thinking about? Is this cancer and the other 4 M's of cancer, such as the metabolic effects, the mass effects, the other medications or other
That's good, David. So what do you do?
What do I do? Obviously, I'll go through take a history and examination of the patient.
Okay.
So the history.
Let's say I'll give you the history now. Patient really cannot lie flat. They literally even get to about 30 degrees head up, and they can't breathe. They have to sit up again. This has been going on for a while, and now we're in the middle of diagnosis of this condition as per oncologists and in coordination with the surgeons. So they're trying to get a diagnosis. That's all we know about the symptomatology, in the sense that lying flat, they get all the respiratory symptoms of coughing, shortness of breath, difficulty breathing, and a feeling of utter terror.
Yep. So then we're thinking maybe this anterior mediastinal mass actually has got external compression on the upper airways and the lower airways as well. So and also the potential of like superior vena cava syndromes with different positioning and causing her to feel a bit more short of breath than usual. And we'll probably do an examination on her and to see what her best position for her is to feel like she's the best breathing position for her, like maybe sitting up 45 degrees or some sort, and also try to examine if she's got any Pemberton sign or any SVC obstruction sign.
Let's say you do that and she's able to, lie on her front, on her side, and lie about 50 degrees head up.
Yeah. So intubating this, like considering this patient is a GA for the CT and is probably diagnostic as well. I mean, we could go through the investigations that she's got at the moment, such as a chest X-ray, just to see like what we saw before, a quick screening test to see what the obstruction is looking like and how big the mediastinal mass is.
Yeah, it looks pretty big on the chest X-ray. Let's say it's what you, but pretend the last image was a chest.
Yeah, it's like that's got to be like significant narrowing of the mid trachea, and so intubation would be probably very difficult for this patient. So the plan, if I were to create one, I would take this patient into operating theatre for at the safest place for securing airway and intubating the patient. I will consider using a spont vent.
I'm going to stop you there, David. So
yeah.
They say you get a request from the radiographer, right? And they say they would like you to give patient sedation or a GA because they need to get a CT scan. Now, what are all like? You've already told me how dangerous you think this is. Is there another way to get a CT scan? Because you actually got the answer already. You asked the question and I gave you some information about the patient, which means that.
Is there another way to do a CT scan?
That is exactly right. What do you reckon? Just think outside the box. How could you do the CT without having to give a GA?
I don't know, use a C-arm?
Unfortunately, the C-arm is a workaround. You asked the question, how else, what's this patient's most comfortable position?
Sitting up at 50 degrees, yeah.
Prone or side, on their side. You could get,
so you mentioned on the side. So you could potentially just do the CT on the side.
Exactly.
Yeah.
So can the scan be done? Yes. In 20 seconds, often scans can be done. So that's good for some patients. It doesn't take long. Head and chest elevated 30, maybe not in this one, but she's very severe, or lateral or prone without affecting scan quality. So this is really good information, David, because to go ahead with this anesthetic in that situation, that's no. So it's really awesome because now you'll never do that and you'll pass this Viva because you didn't do that. So that's great.
Yeah.
That's exactly what happens a lot of the time when I ask this, right? Even myself, when you first encounter this scenario, you're like, oh, well, they're asking me to do a GA or sedation. I need to do what they need to do. But there's only most of the time in this exam, you go ahead and do the thing because you just need to keep acting. But there's a few times when you definitely pause in the exam, and this is definitely one of those. You pause and go, no, not for GA. Let's do something else. And this is the option you might have. Any questions about that before we move on? Cool. There's not many people in Australia with the experience of, hundreds of cases of large anterior mediastinal masses. I'll send you the resource. So Slinger is a Canadian anaesthetist, written very, very well versed in mediastinal masses. Has written the papers on it, and one of those articles that went around like wildfire during the last 10 years probably is an article I'll send around. It's called Anterior Mediastinal Mass Recurring Myths, and so essentially a lot of this is using the knowledge of his hundreds of cases to try and supplement the very lack of experience that many Australian anaesthetists might have if they're not in a center that's doing regular mediastinal mass surgery. So next question, what are the causes? So I want you guys to list the causes of anterior mediastinal mass, and then I'll ask someone at the end of that. Hey, Kitty, are you around? Have you dropped your kids off? I'm going to ask you.
Yeah, I'm back.
Yeah,
I'm
nice.
home. Yeah.
Okay, good. Take 20 seconds, write down some causes. Okay, hey, Kitty, what do you reckon? What are the causes of anterior mediastinal mass?
Okay, so what I remember, the T's.
Go for it.
Yeah, the thymoma, thyroid, cerebral lymphoma, teratoma, thyroid, lymphoma, some aortic mass with aortic aneurysm.
That's fantastic. Kitty, your answer is great. And what I want you to do next time, because you got all the answers, right, is the way you said it doesn't inspire confidence. I don't know if people told you, this exam is a game. It's a dance. It's a very specific dance that Australians love to do. So make sure that we do this dance, okay? So say confidently, I think of the 4 T's or the T's. Teratoma, thymoma, make each one an absolute statement with no inflection and no question in it. It's the difference between getting an examiner very confident that you know stuff or them asking you, are you sure? And that are you sure is a very bad are you sure because you seemed unsure about what you said. You didn't seem that unsure, but there's a big difference between what you said and someone who says, oh, look, I think of the 4 T's, teratoma, terrible lymphoma, thymoma, and thyroid, but I can also think of other things or other tissues in that region, such as vessels that could cause mass effect, infections, congenital abnormalities, or whatever other system you have. So I want you to speak very purposefully like that when you do it.
Okay.
That's good. Does anyone have any other system besides 4 T's or whatever?
I know there's the system of anterior, middle, and superior mediastinum, but it's not as effective.
No, that's really good, right? So if someone asked me what causes a mediastinal mass, I definitely would try to memorize a few things and then go through all the different structures, plus infection, plus masses in each of those areas. But for anterior mediastinal mass, this is a quick list that I think will get you moving quickly. Now, again, I'll try to give as many exam tips as I can. Often the exam starts off with kind of broader questions. What are the preoperative issues in this patient? What's the perioperative risk for this patient? These are very broad questions that really require a very good systematic way of answering. But as the Viva goes on, you get these spot questions. People want to know decisions. People want to know facts. And so you just really need to move on this Viva by giving them facts quickly. So hopefully we'll have a mixture of both of those techniques. If you're asked a broad question, so if you're asked a specific question and you give a big broad answer that wastes time, that is very bad. Likewise, if you are asked a very broad answer and you just say, what is the perioperative risk of this patient? You go high without much else. It seems unsatisfying. So be very specific about what kind of question they're asking me and how I'm going to present this answer. So this is a bit of a nuanced question. When I ask, what is the treatment? What is the point of this question? Anyone can jump in here. This kind of like read my mind. There's obviously a few different causes. What are the treatments for this? But what is the whole point of this question in the context of a mediastinal mass?
The treatment is dependent on what the cause is. We currently don't have a cause, and so we need to get a tissue biopsy, and we need to help facilitate a tissue biopsy in someone who is unable to lay supine or have a is at potentially high risk of any sort of general anesthetic for a mediastinoscopy.
Yeah, fantastic. Okay, so I need to get a diagnosis. So actually, we'll keep going. So if it's a lymphoma, it's non-surgical. If it's most other things, it's surgical. So this is a big deal, right? The whole, actually, we'll keep going with this because I think I've got some other questions. So let's say they still have no diagnosis. The surgeon wishes to go to theater for sternotomy. What do you want to know about the patient's workup? Now, this is a pretty ballsy move. This is a bit unrealistic, but it's to prove a point. Greg, what do you want to know?
So I guess in addition to my routine history examination investigations regarding the patient, I would want to know the history of the mediastinal mass, onset of symptoms, as previously indicated during the CT scan. I want to know the position of
let's say
the patient.
You do a really thorough assessment and you've got all the relevant history that you need in terms of, it's literally just lots of difficulty breathing when they're lying flat and a progression of kind of these respiratory symptoms. There's no other cause of that. There's no other infective cause or whatever. The next thing is you look at examination, similar findings, but nothing obvious, nothing really relevant exam. They don't have any weird, they don't have obvious deviation, but they, they can't lie flat. What do you specifically want to make sure that they've done in investigations?
You want to have some kind of imaging, whether it's X-ray, CT. You'd want to go through that with the surgeons in front of you and discuss, and with the radiologist as well to discuss the airway. You've
got all the imaging done.
Yeah.
Is there any other tests that you want before we go to surgery?
A respiratory function test or a flow volume loop to have a look at the extent of the internal, external compression of the airways. So you want to look at the loops. You may even have an opportunity to have a nasoendoscopy as well, have a look at the upper airways above the larynx, just see if there's any deviation of that. Respiratory function test as well, so FEV1, FEC as well, you might get that with flow volume loops, so respiration.
Let's say they've done all of that and they still have no diagnosis. Is there any other steps that you want to do before you go to sternotomy?
ICU bed.
Anything?
Having a think now, you sort of previous, I guess you want to have a look at previous anesthetics. To see if there's any been done that have been maybe in a relevant time period.
And here's where that previous slide came into play. If I'm going ahead with sternotomy, is there a chance that that sternotomy is completely unnecessary?
There is a chance that sternotomy.
Yeah.
Maybe if it's a lymphoma.
That's it. If you have no diagnosis, you cannot go ahead with a sternotomy in almost every circumstance, because this could be a lymphoma and all we need to do is medical management. And sternotomy in a super high risk positional symptom patient with severe restriction of whatever organ, that's a life-threatening anesthetic. So you cannot, the point of this slide, it's a bit artificial because your surgical and your oncology teams are very good at doing all this, but you would never go ahead with a sternotomy if a patient hasn't been fully worked up to a diagnosis. That would be very, very unusual. That was the point for this slide I wanted to highlight. You worked through that really well though. So you go through the assessment, you're getting all these extra things, and then the whole point of that, I just need a diagnosis. So what can you do less invasively to get a diagnosis? Kitty, what do you reckon?
If there is any pleural effusion, they can do a biopsy under local.
You mean aspiration?
Yeah.
Yep.
Yeah, aspirate.
Anything else?
Endobronchial biopsy.
Yep. So what you're saying is you have lots of little less invasive biopsy type techniques.
Yeah, that can be done under local without sedation.
Yeah, fantastic. Any other ways you can do it? You may have heard of other apertures. So you've talked about pleural effusion taps, absolutely. Endobronchial biopsies, absolutely. There's some more common ones as well.
Can't remember.
No, all good. Awake CT guided, that would be pretty common.
Yeah.
Awake anterior mediastinoscopy, diagnostic thoracentesis you mentioned. And yeah, so in the right center, with the right experience, these can all be done with just local or local sedation. Obviously much more tricky in kids. Again, the massive point of this is that in this exam in real life, you just don't go ahead without a diagnosis. And there's many ways of getting a diagnosis. So again, I want to give you guys confidence that this person who's got the most experience and is well published has written this article that is, essentially imploring us to, you don't need to go ahead in these severe patients. You can do all of this very confidently. And so imagine in the exam, you're faced with the prospect of doing a GA or deep sedation for one of these things in a high-risk patient. This person is saying, don't do it. The patient could easily die. It's a high mortality event, and you just don't need to do that. Just do it away, local, bit of sedation. Any questions about that before we move on? So diagnosis can be made in almost all cases without a GA. Rushing to do a GA can be a critical error. Okay, so let's get back to a broad kind of question now. So let's say this patient presents to the pre-admission clinic for workup prior to the stenotomy. So what do you want to know on assessment? We've kind of covered this before, but we're going to go to a very specific technique when you've got very broad questions like this. Everyone write down, take 30 seconds, write down the things you want to know on assessment in pre-admission clinic. Let's say, this is a completely new patient. They've got some signs on chest X-ray of anterior mediastinal mass. Surgeons, are working this patient up with an oncologist, completely different patient. Let's say they're, 40 years old, female, no other past history on paper, and you're now doing your assessment. Write down 30 seconds how you'd, do the assessment.
All right, so in addition to my usual comprehensive pre-anesthetic assessment, I would specifically want to know the presence of the symptoms, any positional and rapidity of the progression, and any diagnosis given previously. And I will do the full cardio respiratory examination, and in my investigation, I would specifically want to know the CT scan, where it is in any levels, because due to the compression, it is different if it is cardiac level or bronchial level. And aperture, of course, if it is narrowing, is very severe. If it is more than 50%, it is very severe, and there is a likelihood of a tracheal collapse. And so yeah, the kind of location and aperture I would like to examine, and also any blood result related to.
It's good here. So that's good. So you've got this mass here, and you talked to me specifically about some very important things, especially what I liked is you said, I want to know what is the progression, like some of the symptoms and the rapidity of progression. What broad groups of symptoms are you looking at in this patient?
It can be breathing difficulty, so respiratory or cardiac issue.
That's right. So to flag that and say, this mass can affect respiratory structures or cardiac structures, and then I want to know the assessment of respiratory structures. Let me know about your assessment of respiratory structures and your cardiovascular structures.
Yeah. So in respiratory structure, I would like to know the any shortness of breath, difficulty breathing, and I would like to know in cardiacs any hypotensive situation or tachycardia, chest pain, something like that.
Okay, I would offer more in the respiratory stuff. Shortness of breath, cough, hoarseness of voice, dyspnea. Just rattle off a few of the things that you would expect. Cardiac, orthopnea, syncope, palpitations, chest pain. To be able to rattle off a few of these things as a bit of a, patients will often just give you the symptoms. But again, this is a game, get out a good combination. But what I like saying in this, and I think you did this really well, I'm not saying my whole assessment because this is really a specific problem here. Do I really think I'm going to get marks by saying, you know, I would take a anesthetic history about nausea, vomiting, any family history of malignant hypothermia, superfunctional deficiency, allergies, drugs? Of course you'll do that. It happens every single time, but there's a very specific point of difference in this situation. So I'd go, I'm most concerned about cardiovascular and respiratory structure compression. And so I'll ask about those symptoms. And then as well as that, I want to know the positional nature of these symptoms and the rapidity of progression of these symptoms. So you'll notice that this is my kind of structure for most mass lesions, that I will want to know what the mass effect is on other structures. I want to know if it's positional, that really matters for an anesthetic, and how fast this is happening. The other things you might want to add to that are the M's, you know, mass we've talked about, metastases, metabolic effects, and then we talk about medications and mental state. So kind of always worth chucking in frameworks to make sure you're really addressing the point of this assessment. Okay, the patient has tracheal compression. What exactly do you want to know? Babak, what do you want to know? If someone has tracheal compression, what do you want to know?
Hello, everybody, and sorry for being late. So yeah, in these specific patients about the tracheal compression, the things that I would like to know is the extent of the mass that is compressing the trachea and the dynamics of that compression and mechanics of that compression. Is it variable or a constant one? And by that, I would ask more about the history, as you mentioned previously. Position is very important. If on lying back, the patient gets more severe symptoms, it means that it is a dynamic compression, and it is more severe when we are doing the anesthesia for her. And the other issue is that through the investigations, finding out the exact size of the remained open trachea and the airway is another issue that is important for us. A thorough examination, history, and investigations should be done in order to find the potential open area of the trachea and the dynamics of that.
Yep. And let's say you have a CT investigation. What are the things that you want to quantify?
So quantifying that can be done by, firstly, I mean, CT scan is the most important. X-ray can also help us. Ultrasonography is another issue. If it has been extended supraglottically, then the deviation of the larynx and trachea can be investigated more through nasal endoscopy as well. So, MRI also is another investigation that can help us in that regards.
Yeah, so, and one of those really specific things I want to know, which we went through just at the start before you're here, I really want to know what that aperture size is. What is the loss of the cross-sectional area? If it's less than 50%, it's a really big deal. Aperture size to pass the ETT, and what size tube I can potentially pass. Is there any bronchial compression? And what is the distance below the trachea? You know, do I have space from the lesion down to the carina? Because if it's a whole carinal mass with lots of bronchial obstruction, then I know I potentially don't have a whole lung to ventilate. So those are usually the things that I just want to know straight off. So let's go through a bit of a case now. So you've got a 50-year-old with a large thyroid malignancy. So it's not a multinodular goiter specifically. No past history, no allergies, no positional symptoms, but the malignancy is large and extends retrosternally. So yeah, importantly, so no positional symptoms, and there really is minimal narrowing of the trachea. The trachea has just impinged on a little bit, but really looks absolutely normal. Okay, what is your anesthetic plan? Imagine you get asked this in the exam, what's your anesthetic plan? Again, this is a broad question. So the strategy, like previously, is to make a token mention of all the things you do, but please move on, get to the point of what is different about this anesthetic to every single other lap call you've ever done. So take 30 seconds, write down a few answers, and I might ask at the end of that, David Koo. So take 30 seconds first, commit to some answers, highlight those points of difference. Okay, again, the Viva it's kind of quite quick, so it's probably a good balance between instant answers versus a whole 2-minute prep time. So David Koo, what do you reckon?
So I wouldn't particularly change too much my anesthetic plan, considering the history and examination has been largely unremarkable. So in terms of my anesthetic plan, my monitoring would be the standard ANSCA monitoring, ECG, blood pressure, and SPATS probe. My induction would be a modified rapid sequence induction with a good end-tidal O2 of more than 90%. And using a reinforced ETT just to secure the airway for the potential of loss of airway tone and the thyroid mass compressing on the airway with a normal ETT. So I'll use a reinforced ETT for this one. If in any of the history that shows that there was reasons for her to have stridor or an unilateral lie flat, and I'll tailor my anesthetic plan to maybe an awake fiber optic intubation with a surgeon that's capable to potentially do a rigid bronchoscope on site, should there be any issues with airway collapse.
Did you say you're going to do an awake fiber optic for this patient?
I will not use an awake fiber optics for this patient, and I said I would not particularly change my anesthetic technique except for using a reinforced ETT.
Okay, anything else?
I would also consider that the fact that this is a thyroid, it's a huge mass. There's a potential post-op issues with regards to recurrent laryngeal injury, edema. I'll ensure that this patient receives dexamethasone 8 milligrams for airway, prevention of airway swelling. Discussion with the surgeons if they want a NIMS tube, for example, to test for the recurrent laryngeal nerve status during surgery, and also have potentially an arterial line to have recurrent blood tests to ensure that there's no indications for electrolyte disturbances of thyroid storm that should occur.
Yeah, sounds good. That's a reasonable plan. Maybe the one thing I've added to this is just find the least symptomatic position for this patient, just because
I'm not sure whether it's symptomatic at all. Maybe I got that wrong.
No. I apologize for my very normal looking thing. Yeah, no positional symptoms. I apologize. You're right. I've made this extra careful just because let's say this modify. I'm giving you one very obvious scenario, like very basic scenario, and then let's say it changes a little bit from that very specific scenario to somewhat symptomatic or whatever, and this would be my kind of formula for all levels of badness up until severe positional symptoms. So that's why this is here, but I accept your answer. Like, that's a very reasonable technique. So let's say in this situation, let's take this away. We'll just do the induction that you did, which was a modified rapid sequence, and the patient becomes hypotensive with the blood pressure trending down to 70 millimeters mercury. Whoops. What do you do?
I'll do my routine quick investigations for emergency. So I'll check the readings again, repeat the blood pressure, cycle it to 1 minute. I'll ask for help.
You got an outline, sorry. So it's.
Oh yeah, okay, an outline. So again, check the reading. Obviously, there could always be issues with the transducer. Ask for help, alert your anesthetic nurse and your surgical team of the issue of refractory hypertension. I'll treat the cause. Use vasopressors, giving 0.5 milligrams of metaraminol to 1 milligram metaraminol boluses. Also, we'll probably have ephedrine on hand should there be any refractory reasons for metaraminol not working. I'll inform the surgeons quickly. I'm concerned about potential great vessel compression or a tamponade from this large thyroid mass, and they should get ready to probably prep and direct this patient to lift the mass up to relieve the obstruction. But again, I'll still do, that's the last resort. I'll still do a lot of other things surrounding the anesthetic, such as reducing the sevoflurane potentially could be the cause of the hypertension, the anesthetic, and the medication factors. If these patients have not enough fluids, maybe need another fluid bolus, need more vasopressors, and also the surgical factors. It could be the mass just compressing onto the vessels.
Yeah. So let's say what happens now is as the blood pressure trends down to 70, you give some aramine, you give some ephedrine, you give some fluid. You're trying to address all these causes. But after a few shots of this, the blood pressure is 70 in spite of some pretty heavy support on your part. Let's say by the time you've done all this, you and your registrar, you're now running, let's say, 15 milligrams an hour of aramine plus regular bolus of ephedrine. What do you want to do?
I think I'll call for more help and call for other anesthetic support, and also alert the surgeons that this is potentially as a significant surgical emergency that will require a sternotomy.
What's causing this?
It's likely that the loss of soft tissue or muscle tone has caused the large thyroid mass to compress on the great vessels of the heart. So there's reduction of probably the pulmonary artery, most likely, and reducing, preload and afterload, and causing a circulatory collapse.
What else could this be?
This could be a cardiac tamponade. There could be, issues with the contractility of the heart.
The surgeon tells you that this mass is just not going to be doing that. It's off to the side. There's no way it's going to be compressing the heart, is what the surgeon says. What else could be?
And so I think I'll go through in my head the 4 H's and 4 T's as well. Could this be hypoxia? Could this be electrolyte disturbances?
Look at you notice that the SATs are now about 90%. And looking at what do you do then?
I'll quickly turn up the oxygen and FiO2 to 100%, increase the flows, and manually try to ventilate this patient to ensure that there is no obstruction to my airway. Check my EEG.
You find that the pressures are quite high. You're achieving maybe 200 mils tidal volume with 40 of pressure. It seems hard, difficult to ventilate.
Yep, so then I'll continue to try to back this patient and try to ventilate this patient, but also alert the surgeons that potentially are the reasons for an obstruction. Could this be anaphylaxis to medication? Could this be...
There's a rash. There's a rash all over the body.
There's a rash. It's probably likely anaphylaxis, though. I'll probably just drop some adrenaline and give this patient adrenaline. Yeah.
You handled that situation really well. The reason you did so is, I think you told me all the normal causes of hypertension, did lots of normal things first, and you'll find there's a very specific style of thing. I don't know if anyone's really been tricked by this in a Viva. I haven't seen enough Vivas for that, but often the people who are unofficially given Vivas, they might have one lung ventilation hypoxemia. It's all the normal causes of hypoxemia, which is lots of common stuff, plus one lung ventilation. So what you did right, very effectively, was you just gave some normal treatments and did some normal stuff, because this is a hypertension post-induction. And then you started thinking about the tamponade effect and the mass effect on pulmonary vessels and things, which is absolutely right. Now, I just wanted to test you a bit more, because you didn't say, you said causes normal cause of hypertension, but in my strategy is this is most likely induction. Serious things are the mass effect and tamponade and anaphylaxis, because that could easily be happening. And I'm being very picky on you because you're doing well, so I'm chucking in anaphylaxis there. But it could happen, and you don't have all the cues in normal life. You don't have the alarms going straight off. So again, having that strategy of most likely lethal stuff to rule out, and then having a systematic way, which you got to as well. Because you had the system, you told me hypoxemia, and so your backup plan was very effective in getting this answer, even though I was being annoying and harsh about it. That's good. Good. So yeah, then all the special stuff, rescue position, sternotomy, besides all the normal stuff which you mentioned. Any questions about that before we move on to another scenario?
Lahiro?
Yeah, please.
Rescue position would be the position if the patient had symptoms. It would be the position where she has less symptoms. Is that what you mean?
Yeah. You're symptomatic, you've got shortness of breath. Okay, can you be on your, and this is now this question which you're asking, how do you decide the rescue position and what are the rescue positions? Kitty, I think it's pretty much what you said. When do you not have symptoms? Lateral, prone, head up, whatever it is, those facts. Left is better than right, whatever. And then, you really just need a team to sort this out. But yeah, determine it pre-op, at least a symptomatic position. And often, I wouldn't be solely on this, but the anatomical relationship of the lesion and structures would also help you, in guiding that as well. And really, at that point, if I'm doing this induction, and I wouldn't do this if it was a severe symptomatic case. But if it's not severe and it's in that gray area, that would probably okay to go ahead. ascertain all those facts, have techs in the room so you can always turn pretty quickly during the most risky part, which is induction. Any other questions before we move on? Okay, let's get trickier. Case 2, 60-year-old with large thyroid malignancy. Again, not a multilateral goiter. Let's say this patient has some minimal compression of the heart, but with preserved function and output. Okay, that's the case. What is your plan and induction? I might just ask someone straight up, David Wang, what do you reckon? What's your induction for this one? And you may have this is pretty much the same case, but maybe you have a different style of induction to David Koo before you.
So my plan would be to ascertain the position of safety for this patient, lateral, prone, and setting up positions. I would have my resus equipment ready, including surgeon scrubbed, ready with a rigid bronchoscope available, as well as equipment for a sternotomy. IV access in the lower limbs. We'll have 2 large bores in the same lower limb, allowing rescue bypass in the contralateral lower limb if required. I would have, in regards to monitoring, I would have standard ANSCA monitoring, as well as a arterial line on the right radial artery and a central venous access also a central venous access. In regards to equipment, I'll have my standard equipment. I don't have anything else for equipment. And I'll have a trained anesthetic assistant, as well as an additional pair of hands, an additional pair of anesthetic hands. My drugs, I'll have propofol, fentanyl, rocuronium, metaraminol drawn up, and I'll have NORAD drawn up on my CBC.
That sounds good. Your induction sounds like, so you've got all that. Sounds like you're doing like a normal IV induction with fast-acting relaxant.
Yeah.
Is that right? Fantastic.
So in this particular, I wasn't thinking of that. I was doing a spontan vent, gentle spontan vent gas induction in this patient to avoid avoiding your relaxant. So spontan vent induction increase. Spontan induction, applying additional PEEP, additional positive pressure ventilation, and then intubating when convinced that this patient doesn't have any collapse of their respiratory tree with a reinforced endotracheal tube.
Fantastic. You do the spontan vent induction, but as it happens, the patient becomes apneic and starts to desaturate. What do you do?
So this is a emergency. So I would ask the surgeon to apply the rigid bronchoscope and ventilate through the rigid bronchoscope.
They're having so you're trying to ventilate through the rigid bronch. Okay, so right now the patient's cords are constantly doing this.
Oh, okay. Oh, I see. Oh, okay. In that case, I would administer 1 milligram per kilo of. So this patient, I've got concern. This patient had laryngospasm. I would administer 50 milligrams of propofol, applied PEEP, and apply a constant PEEP at 20 centimeters of water to try to break the laryngospasm.
It still seems unable to get ventilation at this point, and the blood.
Yep, I would.
Sorry, go on.
Sorry.
And the heart, that's 85%.
Yep. So I would give 1 milligram per kilo of succinylmethonium, applying and continue to apply positive pressure ventilation. And
you are now able to ventilate the patient. And after you stick the tube down, you notice the blood pressure drops to 60.
So this is concerning. I would check the arterial line transducer to make sure it's in the appropriate position. I'll scan my monitors, looking at the heart rate capnography trace, and oxygen sats, and I would administer 0.5 milligrams of metaraminol and 10 mils per kilo of IV crystalloid. This is most likely due to my induction medication causing a reduction in preload and afterload. However, in my mind, I would still be concerned of features of anaphylaxis and cardiac or vessel compression due to my
Fantastic.
large.
I'll give you some values now. So let's say the transducer is correct. It definitely has trended down to 60. The end-tidal CO2, which was roughly 40, has now dropped to about 20. The patient is tachycardic at 120 in sinus rhythm. And also you give the aramine 0.5 and the 10 mils per kilo bolus. It has minimal effect. The blood pressure goes up to 65, then just down to 60, and it seems like it's trending down further. What do you do?
I would assess the capnography for the trace. If it was a shark fin versus a normal looking trace, may indicate bronchospasm.
Normal trace, but no bronchospasm.
Normal trace.
No signs of that.
And I would also assess. I'll also have I'll also switch the bag to switch the oxygen to 100%. Manually ventilate the patient, looking at equal rise and fall of the chest, and having an auscultation of the chest, looking for any signs of pneumothorax, as well as feeling for midline trachea. If excluding pneumothorax or
the ventilation looks really good, so you're able to have equal rise and fall of the chest.
In this case, I would, this is a medical emergency, I would hit the buzzer. I would administer, this patient still tachycardic, are they?
Yeah, heart rate. So now the blood pressure falls to 30.
So 30.
In spite of repeated aramine doses by yourself and the team, and also the patient is now tachycardic at 150.
Okay, this is a medical emergency. I would commence chest compressions and advise the surgeon and discussion with the surgeon for a sternotomy for elevation of the soft tissue. Okay,
so you're now doing chest compressions. How does this work? So
if the surgeon is ready with the sternotomy, I would ask for chest compressions to cease to allow the surgeon to manually lift the soft tissue, to perform the sternotomy and manually lift the soft tissue off the great vessels or the heart.
Fantastic. As the surgeon gets ready for it, you notice the rhythm changes. It's now VF. What do you do?
This is a concerning situation with conflicting interests. I would advise the surgeon to proceed to continue with sternotomy, but I will also have I will also at this point already have had help. I'll ask for the defibrillator to be brought in and paddles applied to the patient.
Yep, and so paddles applied to the patient?
Pads applied to the patient.
Where would you apply the pads?
So in this case, I would apply them depending on where the surgical access is. Given that it's a sternotomy, I'll still apply if not in the patient's. So I can either apply cutaneous pads or direct cardiac pads if the surgeon has access. If surgeon has yet to have access, I'll apply the pads in the standard position over the left shoulder and right mid-axillary line, as this will be out of the way of the surgical field.
Fantastic. Hey, David, you moved through that really well, and I just want to highlight a few points that I think are really worth highlighting. So first of all, I just kept throwing things at you, and horrible things. Like, you should have seen Kitty's face. She was doing this. She was like, "Oh my God, it's a." But just know that no matter how bad it gets, it's just the Viva, and this is just the dance. And you were dancing that dance really well because you were just giving me information, doing stuff. The one thing which Zoom kind of makes it a bit difficult is, like, there's times that I was talking and you're interrupting, but that was probably just Zoom. In the exam, you just let the examiner direct you if they are. That's a very critical point in the exam, is probably just the Zoom delays here. Blood pressure falls to 30. Sinus tachy, this is kind of like the PEA scenario. So you did CPR, but you also didn't do the standard algorithm, which is fantastic. Standard is, CPR, 1 milligram adrenaline, get you get your defib pads on everything, but you know that the solution is sternotomy, or probably sternotomy and elevation of vessels. So you didn't impede the solution just by following a protocol. This is a very difficult thing to do, but I kind of want to give you comfort in doing this because you talked around it well. It takes a lot of balls to do this exam, but I feel like the exam has these kind of really difficult decision points where there's no protocols. The examiners will constantly make Vivas that are breaking protocol, and I've just seen this countless times. and I'm trying to construct stuff that I haven't seen them do before, but I suspect that they will do it. So anyway, you said, yep, my solution, there's conflicting priorities. My solution is sternotomy. I will do CPR until they're ready, and then they elevate. The next thing you did, and you did this well, I then chucked the VF scenario. So now, PEA, where the surgeon has a solution and CPR is impeding that solution, I pause and let them do their thing. Now, VF is a bit more tricky. And I think you did the right thing, which is, well, I still need to sort it out. Plus, when they do the sternotomy, I can get internal pads in. So at that point, now I know, because I've got this experience, that, oh, great, I'm going to go straight for internal pads, because once you have sternotomy, you can get very, like, too much high impedance from your normal pad placements. That said, I could have also gone, well, I'd immediately apply the pads, defib, try to get them back to a PEA, give adrenaline if appropriate, and then do sternotomy after that. Either way is fine. Open chest is internal pads, closed chest is external. So some really good flow and points there. Just want to really highlight that. Any questions before we move on? What's the
Dose of electricity for internal defib, or do we not?
Oh, that's a really good question. Look, I've seen very low values, like 20 joules, I'm pretty sure. If someone's seen this more recently, please let me know. The cardiac surgeons will definitely know the values for that. But it was much lower.
They never yell it out like Chicago Hope or ER. They just go zappy zap. Yeah.
What was that? Sorry, Greg?
They never yell it out in ER or Chicago Hope.
That's
they just zap.
Yep. Okay, let's do this again. 70-year-old, large thyroid malignancy, not a multinodular goiter. No partition allergies, no positional symptoms, but malignancy is large and extends retrosternally. This patient has now tracheal compression, maybe about, let's say, about 20%. What do you want to know? And so we've already talked about that. Narrowest diameter is 6 millimeters, and there's 3 centimeters above the carina. What's your plan and induction? So just take a minute or so, and I might get a volunteer to describe this new plan.
I'll throw myself in the ring for this one.
Go, Greg. Throw something.
Reluctantly. Because I've only written one word, to be honest.
Oh, which word is that?
ECMO. Well, my rationale is, okay, so what's my plan in induction? My plan would be a good history examination and investigation. We have, I think the most important investigation we have here is this is a subglottic compression with a 6 millimeter stenotic lesion below the larynx but above the carina. The main concern is if we do lose, because of the narrowing, if we do lose the airway or this stenosis becomes even narrower, it could be, and we are inserting a breathing tube below the larynx blindly past this stenosis. If we do lose this, it could result in complete occlusion of the airway, in which case we have only got 3 centimeters above the carina to get access, which could prove problematic. So this is a very tricky airway. It's quite dangerous because we have a very limited limited area for safety, essentially. Getting a rigid bronchoscope past that lesion may be an option if we do lose it. However, possibly the safest way to do this is to secure the deoxygenation of the patient preoperatively by electively putting them on ECMO before induction in a very highly specialized center that can deal with it.
Yeah, okay, and that's pretty fair. I've got to say, I would, not being the expert at this, it would be pretty much a conversation in conjunction with your cardiothoracics team and maybe a cardiac anaesthetist or a specialist in that center, what they would do for this. So let's say what you do is you have a chat with these. And let's say you're in a quaternary center. You have a chat with your cardiothoracic mates, and they say, actually, you know what? This isn't the highest risk lesion. This is greater than, you still got greater than 50% cross-sectional area. We don't need to do ECMO. Let's do an awake fiber optic for this.
Okay.
Okay, and you get to help out on this case. 2 consultants working side by side on this crazy bad case. What do you do awake fiber optic?
So I just want to go for fiber optic or do for the, well, I think everybody else has mentioned our standard plan for induction. So good setup. So standard monitoring.
Again,
in addition to the standard monitoring, we've got an outline in the I think David said right radial, but left radial. We've got a CVC placed electively in one of the internal jaculars or the femoral. And we have preloaded with some crystalloid as well before induction, where assess the patient preoperatively to find an area of safety as well, and also an examination of the neck, because we've got a quite a large goiter. Front of neck access may not be an option because we've got a highly vascular structure which may impede the cricothyroid membrane. So it's important probably to have a rigid bronchoscope available to bypass the lesion should we obstruct as a safety airway. So having the surgeon scrubbed and ready to do that at a moment's notice. The awake fiber optic. Okay, so we're going through this. We would take...
And just to pause, I think the way you moved through that was pretty good. You know, you were saying you're highlighting the points of difference and the rescue positions and the ultimate rescue thing, which is hopefully a rigid bronch if the surgeons think that's valuable, and that let's say they think it is. And now you're going to talk about a awake fiber optic. I want you to think about in real life, but also in this exam, what's the most efficient way you can tell me what your awake fiber optic technique is? Because again, you're dancing the stance, right? Go for it.
So I would go a nasal approach or intranasal approach for awake fiber optic with lots of topicalization to the nose, the oropharynx, the oropharynx and nasopharynx, and the above the cords and through the cords as we progress. So I'd use cofenylcaine to the nose to help anesthetize and also reduce the risk of blood obscuring the view. I would use sprayed lignocaine via a mag device to the oropharynx, nasopharynx, and the back of the throat and the tongue. I'll then use a epidural catheter down the working tube of a fiber optic bronchoscope to help topicalize the cords as I go. I would ensure I have a well pre-oxygenated patient using a Hudson mask flowing at 15 litres per minute. Because I'm using a nasal scope, it's probably not likely. Or I could use Thrive down the other nostril as well at the same time to help optimize my pre-oxygenation. As I approach through the nostril, I would spray as I go using a epidural catheter down the working scope. And when I get to the top of the cords, I would spray directly at the cords as I pass through. I would have a preloaded...
What's your maximum dose of local?
Sorry?
What's your maximum dose of local?
So my maximum dose of local that I would use for a patient like this would be 7 milligrams per kilo.
Where's that number from?
That's the number I've been working with.
You might find that there's...
I think there's 7 to 9 I've seen, so maybe 8.
Okay, sure. I've seen 9 as the awake fiber optic number.
Yeah.
Whatever you can quote's fine. 7 sounds a bit conservative from what I've heard, but that's fine. It's in the ballpark. Go for it.
Yeah. In terms of...
Do you use opioid?
Yeah. So in terms of patient comfort, I would ensure they have a cooperative patient. Yeah. There are arguments for using sedation to help increase patient comfort for this procedure. However, it does increase the risk of obstruction of the airway or over-sedating and anesthetizing the patient, especially in cases such as running
language structure. Just tell me what you're gonna do, not the problems with it.
Okay, I have the most experience with propofol. I would use a very low dose propofol infusion at a TCI to keep the patient cooperative. However, not so much that I anesthetize the patient and cause more problems to myself. So I'd start slow and I'd increment even slower to make sure that the patient is comfortable and cooperative throughout the procedure.
Just give me a rough guide. TCI what?
TCI, so I'd use an effect site of 0.3, 0.4, and titrate accordingly by 0.1 microgram per mil to achieve the desired effect.
Is that okay? Is that all your plan?
So once I'm through the cords, spray the cords, progress the fiber optic scope past the lesion. When I'm satisfied I'm past the lesion, I'll pass off preloaded long endobronchial tube past the lesion and confirm that I'm in the right spot by visualizing the carina as well. Then we withdraw the fiber optic scope and catch up the oxygenation and ensure that I can oxygenate.
Yes. And what was your confirmation again? I missed that.
I'd visualize the carina,
yep.
But I'd also, I'd visualize the carina by looking for the longitudinal muscles. I forget the name of the muscles at the moment. And then I'll also progress down the right bronchial tree, progress and visualize the early offtake of the right upper lobe main bronchus, and the right middle and right lower lobe bronchi shortly afterwards. So that was my confirmation of where I am at the carina, and that is the carina where I am.
Okay. At that point, do you give the anesthetic?
So once I'm through the cords, as long as the patient's cooperative, then I would come out. I'd ensure that I'm still able to ventilate and I have a secure airway, and then I would give the anesthetic. I would not give the anesthetic until I could confirm that I had a secure airway.
And there's one thing that's probably really worth mentioning. What is your confirmation you're in the trachea? Absolutely.
Oh, sorry. So I confirmed that I didn't have high pressures on ventilation. I had return of CO2.
Yeah, great. I checked the inside CO2. Hey, Greg. So this is again because we're learning how to dance this dance. I want you to be, and this is just not a massive criticism. Actually, hold on one second. So I've just got to get this call. Sorry about that, guys. I think, Gary, you could have got through everything quicker, and that'll just be a matter of practice. So I'd get all my usual setup. I'll put an outline. My main plan is an awake fiber optic, passing the tube past the past the lesion and still above the carina. To do this, I would do make sure the patient was comfortable. I would run whatever dose. I often just give one of Midaz, but very conservative dose of a hypnotic. I'd give maybe 500 mics of alfentanil, or we could say run REM infusion. I'd use a maximum of 9 milligrams per kilogram of local anesthetic, in which I'd do a stepwise procedure of cofenilcaine, a couple of sprays to the nose with a nasal approach. I would then use the DeVilbiss atomizer to atomize through the airway and ensure that I've got a good vapor present. And I've done this for, say, a couple of minutes. And then once I get down with the fiber optic scope with a loaded reinforced tube, I'd spray the top of the vocal cords and then into the trachea as well. I'd pass the tube as best as I could past the lesion, and then ensure that I'm above the carina, take the tube out, connect it, make sure I've got end-tidal CO2 and I'm able to ventilate appropriately, measure the tube at the right location at the teeth and mark that. And then I'd paralyze the patient and give hypnotic at that point. I personally wouldn't go down to me, there's not like a double even tube situation where I have to check the right bronchus to take off. I've just never ever done that. I don't know anyone who's done that, so I probably wouldn't say that. But I just get through it a lot quicker because there's many ways of doing this, and whatever you say is fine. It's not real life where awake fiber optics so many times get stuffed up. You just get to be whatever you want to be. Good. So let's go then. You've done your awake fiber optic. Sats dropped to 90%. Greg, what do you do?
So my sats, sorry, this is when I've got the tube secured, or is this?
Sorry. Let's say as you're going in, the sats, you got the tube down to the vocal cords, but you haven't passed it through, and the sats dropped to 90%.
Okay. So my sats have dropped to 90%. I would examine. I'd have a look at the vocal cords to make sure they're adducted and they're closed and they're not. We haven't got a case of fluid spasm or spasm of the airway caused by my instrumentation. I would ensure that I've got some passive oxygenation either by Thrive or high flow nasal prongs or Hudson mask. I would assess the patient as well to make sure they're not so deeply anesthetized. But at the end of the day, what I would do is I've got to make a decision whether to continue on with my wake fiber optic or come out and re-oxygenate the patient, in which case I would come out, I'd re-oxygenate the patient and pass again.
At that point,
I'll come back to us a bit.
At that point, you notice that the patient is actually quite obtunded. It seems like your registrar put the TCI, instead of 0.3, they put it to 3 mics effect site. And that was a bit of a mistake. What do you do then?
So I would stop the sedation, or I ask the registrar to stop sedation. I'd come out. I would come back to my position of safety and go back to bag mask ventilation with positive pressure airway to try and to re-oxygenate the patient, and then I would attempt again with fiber optic.
The patient is apneic still. The SATs have dropped now down to 70%, and you're unable to ventilate with Dell and all your bag mask techniques.
So this is an emergency. We've in this situation, unable to ventilate, most likely off the airway due to essentially giving a general anaesthetic, in which case I would announce this to the surgeons and ask them to pass a rigid bronchoscopy down to apply oxygenation past the obstruction.
Okay, good. And you already told me about
I hit the button, call for help.
No, you're fine. The fact that you told me about your rescue position and the rigid bronch as a backup, I haven't seen the rigid bronch in action. I don't know how swift it is. I really haven't seen it in a rapidly desaturating case like this. But still, this is what we talk about.
Yeah. Sorry. And get into a position of safety as well.
No, you said that before. So the fact that you said those things made this situation a lot more easy for you to talk through than if someone hadn't mentioned those, because you've already pre-prepared for the eventual disaster that happens in the VIVA. Rigid bronch rescue, position, and eventually sternotomy if it really gets to that point. Hey, so when I was going through my study for this back in the day, one of the cardiac anesthetists where I trained, he gave me a suggestion for 3 groups of patients, and I thought, this was a really good framework that I can use for most patients. So take it for what it is. It's literally just someone with experience's advice on how they approach it. But I feel like it gave me something to hang a method onto. So essentially 3 groups of patients, mediastinal mass with no symptoms and no cardiovascular or airway obstruction on imaging. So this is really just mediastinal mass with no other apparent effects. The next one was with minimal symptoms, but imaging shows some compression, but not catastrophic compression, and then severe positional symptoms due to airway or cardiovascular compromise. So 3 groups of patients. Really, the first group continue as normal, but with a really cautious approach. I think these are the ones we often see in our practice. And the first and second group, really, you could do all of these as extra things. Usual preparations, but monitoring and an outline, maybe a CVC if you want to get inotrope directly there. IV in the lower limb, especially if that obstruction is cardiac venous inflow. And then surgeons in the room prep for sternotomy or rigid bronch, and make sure they're able to do that. The technique, spont vent is key. So often this is the one that's described. If there's tracheal obstruction, awake fiber optic, position the tube past the obstruction, or spont vent induction with SIVO or whatever technique you want to use. And this was a really interesting thing that he talked about, which I think one of you guys mentioned as well. Gradually take over positive pressure ventilation. Check if it's tolerated. Suddenly you're dropping a bit of preload. Make sure that you can give decent amounts of pressure and this cardiovascular system is still tolerating it. Blood pressure isn't dropping, and only then give muscle relaxant. And so this is just, again, a very cautious spont vent induction, generally speaking. And then you've got 2 situations, life-threatening airway or vascular compromise. And I think the scenarios, we've kind of drilled that already, but maybe you can awake the patient rapidly, but often not. Reposition to the least symptomatic position or the rescue position, which we mentioned, and then rigid bronch for lethal airway or sternotomy and surgical elevation of mass off the great vessels for lethal cardiovascular compression. Maybe that sternotomy could also apply for airway compression, depending on exactly where it is. So a few of the details, Actually, I might ask this question of you guys. Who wants to answer? When is rigid bronch unlikely to be helpful? So imagine I gave you that last scenario. When would you have to really think about something other than a rigid bronch as your rescue? Thinking outside the box, when would a rigid bronch not rescue? Think about what they need for a rigid bronch. Imagine those ENT cases where you, yeah, I'll leave it at that.
Well, rigid bronch is very rigid.
Two statements are true. I like it.
I mean, if it's really, really narrow and it's the narrowing of the trachea is really small and you can't even fit a rigid bronch, there's potential perforation and making things worse.
Maybe the rigid bronch is bigger than the aperture and it's a very restrictive thing. How about the access? What kind of maybe anatomy would mean that you couldn't get that rigid bronch in?
I mean, for rigid bronch, they probably have to really hyperextend the neck, and positioning of the patient would be difficult.
Beautiful. Yeah. So maybe you got C-spine immobility, really difficult upper airway anatomy. I mean, if we can't use a Mac blade on something, then what are the chances of someone using a really, rigid bronch that's big diameter? So plan for airway loss, have a discussion with the surgeon. I can just imagine that once all of this rigid bronch mediastinal mass stuff becomes a cliche, what do the examiners do? They make it next level of difficulty. So have a plan for that. This may be that time where you just go, oh, well, if we can't do a rigid bronchial rescue, maybe we need ECMO or something like that. The article that I was referencing also goes through flow volume loops, that they have a very poor correlation with the degree of obstruction. One study of 25 patients with Hodgkin's disease found that none had the pathognomonic pattern. So really, the theory doesn't necessarily translate to what's in practice. So be very cautious about that. And is standby cardiopulmonary bypass useful? I haven't asked, hey Babak, what do you reckon? So when people say, I've got this severe lesion, let's crack on with the induction and we'll have ECMO or bypass on standby. What's the utility of that?
So I would say in emergency, it would be very difficult to install that. But if I am really concerned that I cannot access the airway, or there is more than 90% or something very great concern about the cardiovascular compromise, then why not starting the ECMO or cardiopulmonary bypass first, and then trying to proceed with the surgery?
Absolutely. It takes 5 to 10 minutes in best conditions to cannulate and establish circulation and oxygenation, even with the prime pump and prepare team. So everything, if you have everything going to your favor, still 5 to 10 minutes, and that's a lot of downtime and neurological injury in someone. So yeah, cardiopulmonary bypass by femoral cannulations prior to induction has been safely performed in adult patients. Definitely, if someone's heard differently, please let us know. But this is, standby cardiopulmonary bypass. It's just not a thing for these cases. Mediastinal mass in children. So why are children at more risk for anesthesia mediastinal mass? Kitty, what do you reckon?
Because they desaturate quicker.
Okay, what else?
It's hard to get history and symptoms from kids. So, ask them what is the best position where you have less symptoms and history.
Yeah, absolutely. Anything else?
Blank.
No, all good. So yeah, children overrepresented in adverse outcomes. It may be due to more compressible nature. So, they've just got softer cartilaginous tissues around. Small decrease in airway lumen is a large increase in airway resistance in an already smaller airway. And yeah, exactly what you said, difficulties of clear history and symptomatology. So you may really not know a lot of the detail and how bad this child is. So yeah, beware the pediatric case. Anesthetic deaths have mainly been reported in children. Children with bronchial compression greater than 50% cannot be safely given a GA. Safe awake techniques are also very difficult and potentially not possible. And so what are the strategies to avoid surgery in children or decrease risk? diagnose at peripheral sites we talked about. So, really need to get that lymphoma diagnosis potentially. Effusions, peripheral lymph node biopsies, bone marrow aspirates, local, these are all possible. And better modern imaging may also give the diagnosis. Sometimes pre-treatment with chest irradiation and steroids to shrink the tumor prior to surgery, decrease the symptoms and mass effect. That's also useful. And then this article, which I'll send you guys, they talk about kind of the risk factors for perioperative complications, and they have a few maybe slightly different numbers, but these are kind of obvious things. So imaging findings, bad narrowings, carinal bronchial compression, great vessel compression, pericardial effusions, these are all really bad signs. And if you're this anesthetic exam is not about you being a cardiothoracic specialist. Often it's knowing when things are really bad and you probably need to go and go to the right referral center. And what do you do for diagnosis of local anesthesia? It's not enough, so you can probably get do things with dexmedetomidine and ketamine for sedation. And that's probably a pretty reasonable way of doing things. And then just knowing your dexmedetomidine doses and how you'd run that is probably worthwhile. Any questions?
Hi, Rahil.
Yeah.
In regards to dexmedetomidine, I've never seen in Australia, but is it available in most of the hospital?
Yeah, absolutely. I just used it last week for an awake voice box kind of surgery. And yeah, we essentially loaded 1 mic per kilo low. Just get ready for bradycardias. So I gave glycopyrrolate 0.2 milligrams and had atropine ready because the patient became quite bradycardic. Otherwise, it was really very stable. And then I ran 0.5 mics per kilo per hour. Just remember, it's not mics per kilo per minute, it's mics per kilo per hour. It takes about 20 minutes for onset, and it's got a slow offset as well. So at the end of the case, not for sedation, but for the case, as soon as they started stitching up the muscle layers, then I just turned the dexmedetomidine off. In this kid, I would potentially go even more cautiously just because I've got such a high risk problem. So maybe I'd go 0.5 per kilo load, followed again by another 0.5, and started at 0.2 mic per kilo per hour infusion.
Yeah, what is your impression of the usage compared to any ketamine or propofol, or is it any?
Well, you don't get the hallucinogenic effects, I guess. So I think my preference, because I've seen it work quite well, is probably dexmedetomidine for this. I don't want the kid to get too, distressed with ketamine. So maybe I'll try dexmedetomidine first. Yeah.
Yeah, thanks.
Beautiful. So that's kind of a quick session. Those just mainly the highlights I wanted to go through with this. So important elements on history, really trying to focus on the point of difference. It's trachea bronchial compression, it's cardiovascular compression, and my assessment is now going to target those things because all the usual stuff is boring and already mentioned. If this was a Viva, that's definitely how I do it. If this was a short answer question, I would write the points of difference first, and if I had time, I'd follow with the whole system so that they know that I've got a broad range of what I'm going to talk about. What we mentioned before, you really need that diagnosis, which can be done with local anesthetic and very minimal sedation. So rushing ahead to do that sternotomy without a diagnosis was probably a critical error. Don't rush ahead with GA or deep sedation. We talked about the 3 groups of patients and just a suggested formula for how you might think of these inductions, and then a careful GA plan, and obviously bypass in the worst cases. But we also ran through some scenarios talking about how things get tricky, making sure we rule out all the normal stuff as well as tackling the really problematic things that we're worried about with the compression and the mass. And then also how to kind of juggle conflicting priorities. Let's say in this example, CPR versus sternotomy and elevation versus VF, and having something to I guess say to that. These are the articles, but I'll send those around to you in that group. I'll edit this video and upload it to YouTube as well, so you can have a look and think about it for next time. Could everyone fill out this evaluation form right now? Just because if we don't do it now, it never gets done. So please do that, and give me any suggestions to change the session if you would like anything else on there. Please let me know. And yeah.
Lahira, can I just ask a question? Everyone mentioned about lower limb IV access. Do you only do this if the patient has any cardiovascular symptoms, or do you do, depending on like the size of the mass, expecting to have any cardiovascular complications after induction? I did a patient with a very large groin the other day, and I mean I didn't put lower limb IV cannula.
I think it's, look, I think it's one of those things where who knows what is going to happen. It's such a dynamic thing. Like, you know, our N equals, you know, our sample size of experience is going to be very low. So, you know, if I had a mass that was causing any kind of compression of these upper vessels on both sides, I would probably always put a lower limb and just keep using the lower limb with a fast flowing drip, or maybe even a femoral CVC, because then I'd get, you know, I pretty much really do want my inotropes and drugs in at the point of the heart straight away. So I'll probably put a femoral line in for those really high risk cases. But yeah, I think 99% of the time you'll probably be fine. There'll be some kind of flow into the heart, but I don't want to be that 1 in 100 or 1 in 1,000 times. Beautiful. I'll stick around for a few minutes. Yeah, please, if you have any questions, let me know.
Well, here, can you go back to your slide on the 3 groups of patients?
Yeah, of course.
Yeah, in this particular algorithm, does it take into account presence of dynamic airway obstruction, or is there any like utilization for?
If dynamic airway obstruction, as in, are we talking about breathing or?
Yes. So for variable intrathoracic obstruction on your respiratory function tests.
I think if at any point you get to category 3, I would consult widely and have a low threshold for referral to a transfer to a bigger center. Because you know, it's at any point, my non-ideal situation is catastrophic. So if we're saying, yeah, most of the time it's good, and then with some kind of maneuver or some kind of positioning, it becomes very, very bad, I'd treat that very seriously, like a category 3. Again, this was, that wasn't a question that was asked of my consultant back in the day. So that's just my gut feeling of the situation rather than, and again, this is just one person's method, which sounds reasonable. Does this exist? Is there any real theories of how this should be done? I haven't seen anything published, so this is just a reasonable approach.
Because I've got the other framework of the safe, unsafe, and uncertain category, and the safe is asymptomatic, no issues on no compression on CT, or less than 50% narrowing on CT. The unsafe is severe symptoms, so unable to lie flat, or any pediatric patient. And then there's that uncertain where they're pediatric or they don't have any further investigations, or if they're asymptomatic but have greater than 50% stenosis on trachea, or asymptomatic plus symptoms of, I think, dynamic airway compression or variable airway compression on our RFTs. I think that's what.
It sounds very similar to this.
Yeah.
So I mean, we're really just fiddling around at the edges of what we think something is, percentages here and there. So, I'd be very happy if someone had a format that sounded like that, just because this is, it really isn't evidence-free zone. It's so many variables that,
Cheers. Thank you.
No worries at all. Babak, go for it.
Lahira, my question is, might seem a bit violent, but I have really seen these patients. So we have a patient coming with a very large goiter, and there is an emergency surgery for the patient, either an abdominal surgery, or when they wanted to do the biopsy from the thyroid mass, it started bleeding and the mass is expanding. So in case that the patient is not fasted, has difficult airway, upper and lower, I mean, we have troubles supraglottically and infraglottically as the thyroid is extending down posterior to the sternum. Do you have any idea in that situation?
Just to clarify, you said we've got a thyroid.
Thyroid. So sorry, I'm out of chart. So
let me clarify. I heard everything you said. That's fine. Is it a multinodular goiter or is the diagnosis uncertain?
We were not sure about it. So it was a very big mass in the front of the neck.
Yeah.
And we knew that it extended down posterior to the sternum.
Yes.
And there was a biopsy of the thyroid. And
Yep.
then it started bleeding and the hematoma was expanding. And then they wanted to do this and the patient was not fasted. So
yeah. So the first thing I do is I care less about the fasting. So I in my algorithm, I don't even worry about that because now I've got far more important things to worry about. So this is essentially multiple level problems. The first one is I've got an expanding airway problem. So surgeons in the room need to release that pressure. Otherwise my airway is obstructed. So you can do that with local anesthetic and potentially a bit of fentanyl to try and avoid problems and then direct pressure onto this area as well. So if you've got a very vascular tumor that's bleeding, a bit of pressure on the site of biopsy, that could be the solution. That's common sense. Or if I've even beyond that, I would need to do multiple things. This is the true definition of a crisis. So what I do is I need to manage the oxygenation and airway while I have the surgeon managing the lesion itself. So what does this mean? This is a difficult situation. They're working on, stabilizing this mass, and I'm going to have to work on trying to get the airway. So depending on what happens with the breathing and airway and whether it's collapsing or not, I'll have everything ready for a couple of things. I would have, video laryngoscope and, a couple of different tubes ready, and LMA just in case I can't get enough stuff past there. I'd also have surgical access ready, knowing that I've got a goiter. It's going to make it very difficult, but still I'd have a scalpel bougie size 6 tube ready for that as well as all the other things. Get another surgeon with a rigid bronch. Make sure you've got enough techs to change the patient to the least symptomatic position, which, let's face it, we don't know. So it may just be, if they have a critical collapse, you get them left lateral, give them oxygen to take the weight off while the surgeon does some temporizing maneuvers. So that's how I think about this.
Yeah.
Difficult situation. I say it's difficult. I talk about the problems and then highlight them in a very crisis resource management style way, which is surgical problem, they sort it out. My problem, I sort it out. And then I go into the detail. I've given 2 categories. And then I say, I would then do this for my airway, which is plan, ETT plan, LMA plan, surgical plan. Surgeons talk about their plan. And then I've got some rescue maneuvers add on because of this specific situation. That's probably how I talk about it. And I'd ignore the aspiration risk because that's not something we can solve. And it's low risk overall, I think.
Thank you.
Thanks very much, guys. Any other questions, feel free to ask, but I'll send those articles for some light reading later.